everyone, I'm Dr. McGuirk. I'm sitting down here with Dr. Booth, and we're going to talk to you guys today a little bit about spines.
Yes, spine, neck, thoracic, lumbar, all of it.
Everything, top to bottom, bottom to top.
It's all the spine. All right. So you've been in town how long now?
So moved here 2020. So I've been in town about 5 years.
It was a fun time to start a practice.
Yeah, it was COVID.
Yeah.
We did not see each other's face for about a year.
Yeah.
Yeah.
Yeah. And I'm glad I can see your face now.
You were here. Yeah.
Beautiful individual. Yeah. I got here 2017.
Okay.
Yeah.
17.
Mm-hmm.
And you guys have loved Knoxville.
Yes. Yeah. Yeah. It's pretty good. Been between our families, so it's been a nice place. It's not close. It's not far from y'all's family either. North Georgia.
No.
Yeah.
No. Yeah. Family up in Georgia. So we knew we wanted to get into a town that was plenty of access to fun outdoor stuff. Love the river out here.
Yeah.
Been out with you guys and your family.
Yeah. Yeah.
We've got kids around the same age. So occasionally we'll get out on the water and enjoy some time. And
trying to get them married eventually. So that'd be nice.
Plotting.
Yeah. Plotting.
But anyway, so tell me a little bit about your practice here. So 2017.
Yeah. Trying to kind of get your footing and try to figure out exactly kind of where practice will take you. Because when you come out, you're trained to do everything. But you always want to kind of find your niche about what you want to do or what you want to be known for. I've always enjoyed cervical. Did a lot of cervical in my fellowship. And with newer technologies, with the disc replacements, that's kind of become a place I've really spent a lot of time trying to develop that practice and really get the word out there about that, about the benefits.
Yeah,
all the benefits
absolutely.
of a fusion, but no loss of motion, quicker recovery, do them in the surgery center. It's great.
Yeah.
It's really good.
Any particular ideal patient you like to see for cervical disc versus traditional neck fusion?
Yeah, I mean, it can't be too arthritic, too degenerative. Unfortunately, at a certain age range, they're really not that beneficial because with the pathology of degeneration in the neck, you're really just trying to deal with the disc degeneration, which is where it's more concentrated in the cervical spine. Then if it starts translating to the back joints of the spine, that's kind of where it starts losing its benefit. And then doing a fusion would be better for you at that point. But usually, typically younger. A lot of younger patients, athletes will herniate disc. Unfortunately, they just don't get better with injections. One of the things that you specialize in. And then, look at surgical options if they fail.
Yeah.
And disc replacement for age range people like that is usually pretty darn good. Now, I put them in patients at, 60 to 70. They've done very well. But that's not the most normal age range I put them in.
Yeah, I think recently, so I had a patient came to me and they were younger, single level disc, push out. They had a clear C6 radiculopathy down the arm. We had treated her with 2 epidural injections, just was not getting the relief we wanted. Sent her out to you. Yeah. I've actually since heard back from her. She's been doing fantastic. So she's coming to the office and she's happy as can be. And one of the conversations we had in the office before talking about surgery was just that neck mobility and her wanting that and thinking, down the line, you lose some of that mobility with a fusion, right? And so some of those adjacent segments, and maybe degenerating, potentially being an issue. That was her main concern. Yeah. So.
With the disc replacements, if you look at all the research, when everybody thinks about fusion, it's the adjacent level disease. And that's the unfortunate part of doing a fusion because you're not removing that stress from the level, you're translating it to the other level. So they see more stress and they can degenerate faster. But with the disc replacements, that goes down significantly. But look at most research, it doesn't go to zero. Still a man-made product, it's still surgery, which causes an insult in the area. And it's still not completely normal neck motion of what, a God-given disc is. But it still decreases that rate of adjacent level disease. And look at all the studies. If you compare 1-level fusion versus disc replacement, or even 2-level disc replacement versus 2-level fusion, the disc replacements do better. Decreased risk of revision surgery, decreased risk of adjacent level disease, and they still get the patient satisfaction outcome. which is great. Even with a fusion, it's still excellent. But, younger patients, you want to maintain motion, you can. One of the areas they're looking at now is hybrid constructs where one level's fused and another level gets a disc replacement. Well, it's technical off-label use of the implant. And I talk to patients about that. If you look at 5-year studies so far, the hybrids do better than a 2-level fusion. So that's kind of where we're looking at now, running more studies on that. Yeah, but going back to injections, before you came to town, we didn't really have anybody doing isolated like nerve root blocks in the neck. I don't think there's anybody in town doing those.
Yeah, like selective nerve root blocks.
Yeah, especially in the cervical spine, because it's a pretty dangerous area. From a non-op standpoint, in particular, that the normal epidural, which is kind of at the base of the neck, kind of like what you said, like a shotgun approach. What is the benefit of doing those transforaminals or the isolated nerve blocks in the neck?
Yeah, so I think there's probably 2 ways to look at it, right? So you can do the selective nerve root blocks where you're just using local anesthetic. So if you've got, say, like 2 nerves that look like potential pain generators, you're really trying to minimize your surgical footprint. Yeah. Which level do I want to operate on? Yeah. Well,
I've sent people specifically to you for that because you're looking at 2 levels and the pattern's not really clear where the nerve pain's from. So
there could be some benefit to just putting some local anesthetic on those and seeing, hey, does all my pain go away? Yeah. And if it does, great. Maybe it's just that one nerve root and we can get away with operating on one level. Or maybe, from a therapeutic standpoint, putting a little steroid in there and doing that. Putting a little steroid in there, do a little transforaminal there, might be a way to calm that one nerve down and see how they do long term. Yeah. So I think when you look at some studies, going into an interlaminar approach from a little bit lower, floating the medication up, just kind of looking at how much volume you use, and trying to match at least that with some steroid to hit that level. Reasonable approach. Some people will come in a little bit lower and thread up a little catheter, and they can do that to kind of hit one nerve root that they want. And coming from the side, as long as you're careful, you pay attention to where that vertebral artery is. Yeah. You kind of use your bony anatomy to your advantage, where you can touch down towards the facet and kind of slide into that foramen. I think there's a lot of ways to make that procedure safe. But I find the benefit, especially in some of those upper cervical segments, like your C4s and C5s, where, you think shoulder, and that can also blend in with some true shoulder pain. You've got to tease those out, and you kind of want to be a little more diagnostic in a sense. Yeah. I think that might be the best utility that I found for it. Mm-hmm. When you get a little bit closer to the bottom, where the interlaminar approaches anyway, I think you probably get pretty equal relief if you're looking for just therapeutic effect with steroid. Yeah. So,
yeah. Getting back to what we're talking about. So when you're talking about these different types of injections, interlaminar versus transforaminal, what exactly does that mean? Like, so if you're talking to a patient about this, how would you describe it to the patient?
Sure. So I think, when you look at the spine, we know there's little bones everywhere, and between each bone is a disc. Mm. And if you look kind of off the back, there are little holes off the back between what we call lamina, right? And so the lamina, form the interlaminar space. And so you can go in through the back. Your needle is approaching midline and will eventually, traditionally what we like to do is touch down on some of that lamina, slide forward, and we engage a little ligament, okay? And that's kind of almost a safety check for us. Yeah. We can check, we can check separate views, and then we can, kind of proceed through that ligament to get into the epidural space. Mm. And so that's one way in. And then the other way, so if you're looking at that model, we probably should have brought a model up here.
That would have been helpful.
Awesome. But you look from the side, and between those bones, you also have little holes, foramen, where the nerve roots will come out of individually. And so you can take a needle and go down to one specific nerve root, cover the nerve, and get the medicine into the epidural space that way as well. Yeah. And so that would be considered more of a transforaminal injection in approach versus kind of a midline interlaminar. Yeah.
So the interlaminar, I guess, is more what people think like a traditional epidural.
Right. Okay. So I think, Yeah. And so we hear all the time, I've had nothing but painful epidurals.
Yeah.
Every time I've given birth, horrible. I still have pain. You're like, well, it's different. Like we're using image guidance. We are still hitting that interlaminar space. But with the image guidance, it's much more comfortable injection. We're not kind of trying to feel our way in by bumping bone and eventually getting where we want. So very different experience, hopefully. Yeah.
Also, no lower extremity paralysis for a little while.
Yes. Yeah. No catheters. We're not, dripping in anesthetic. Yeah. And so, it's, but yeah, I think, we touched on earlier at some point about, potential benefits to going in interlaminar versus coming in, transforaminal. And so, if you're talking about, lumbar spine, I like to use the interlaminar approach for coming into the middle to really cover more of a broad space.
Yeah.
So some of that central canal stenosis, if it's really tight, I might bring it down a level and put an interlaminar there, higher volume, and just kind of cover everything a little bit better that way. Yeah. Versus, you've got a disc that's bulging out the side, pushing on the nerve in the foramen. Yeah. They're probably going to do better with a transforaminal injection. Yeah. And then the neck, you get a little bit higher up in the neck, and there's probably a little bit more benefit to coming in for a transforaminal approach. The safest place for us to access is usually lower, kind of the base of the cervical spine, in the upper part of your back where your ribs are, your thoracic spine. Yeah. So,
the big bump on the back of your neck that everybody has. That's typically, when taught in med school, it's typically C7.
Yeah.
So you kind of feel in that area and kind of guide the needle between those two bumps, which are the bumps or the spinous process. Yeah. And those spinous process flow into the lamina, which looks like a wing of bone. So when we're saying interlaminar, we're talking about going in between those two little wings of bone. And then with
the wings, I like it.
It looks like a wing.
That's the best way to describe it.
It looks like a wing. Huh. And then the transforaminal means into the foramen. In foramen in medicine is a fancy term for tunnel, and stenosis is a fancy term for narrowing. So if you ever hear stenosis in medicine, it means something's narrowed. And foramen usually means like a tunnel. And so when you talk about transforaminals, you're guiding the needle directly into that tunnel where the nerve root exits. So you'll get more of a very this is going to sound really stupid, but surgical approach to blocking the river. Yeah, it was bad. I'm sorry.
No. I think like very specific. Like we've got one nerve, we want to hit that one nerve. Get one response from that nerve. Yeah.
Well, going back to what you're saying too, we both see this, and we have partners that are other specialties, shoulder, hip, knee. Teasing out where someone's pain is sometimes in their extremity can be hard. And sometimes it can have double crush where you got pinching in your neck or pinching in your lower back. You also have hip or shoulder, knee pain. And so doing the selective nerve root blocks that Dr. McGuirk does can really help tease out, is this coming from your neck? Is it coming from your shoulder? And that way we know where to send you. And sometimes it can be frustrating for patients because I can see it because, people, I've been passed around, and that is frustrating. But, we're always trying to do the best for the patient, because when you're talking about surgery, one, you don't really want to have surgery, but two, if you do, you want like minimum amount of surgery possible. So if you know exactly where the majority of the pain is coming from, then we can take care of that problem. And a lot of times once the majority of the pain's gone, even if they have some residual stuff coming from the neck or coming from the shoulder, a lot of that stuff can be dealt with non-operatively. Mm-hmm. So it can be frustrating, and I get it because I've had back surgery myself. And so I get the frustration because you're in pain. You're just like, someone just help me. And we're just trying to make sure we're doing the best thing for you.
So, yeah. I'd say very frequently we see people, you always talk about like multiple layers of pain. Oh, yeah. And was like, your pain's kind of like an onion.
Yeah,
you've got
multiple layers.
You peel off one layer. Oh, there's another one sometimes, and part of it's just, you may start with nerve pain, but then that nerve's been irritated so long, the muscle's angry. You've got a muscular component of pain. Yeah. You may have some underlying hip issue, and you've got two, I think, like black holes of the body that we'll deal with where everything goes into those. Yeah. So you're like shoulder blade area, and then like the butt area. Yeah.
Yep.
Low back, butt pain, and shoulder kind of pain are two where you've really got to tease out what's going on. Yeah. And so, good physical exam, just tuning things up. And then sometimes it's still really difficult And, you know, we'll kind of lean on the injections a little bit and people's responses to those to help make us feel like we've got the right diagnosis for you.
Yeah.
So,
you know, I'm pretty sure you heard this in med school too, but, you know, everyone preached physical exam. And, you know, you kind of brushed stuff off because, you know, you're new, you know everything. Really, honestly, God, physical exam is super important.
yeah.
I mean, just touching somebody, moving a joint, doing certain things, you can actually figure out even without injection or imaging. I think I've gotten to the point in my career, I can look at, someone can tell me, I can do the exam, I can look at the x-ray and be like, this is your problem.
Yeah.
And I'm pretty spot on a lot of times, not to brag.
Yeah.
But, you know, but we always get the imaging just to make sure because, you know, not everybody presents the same.
Yeah.
I read it was an article probably 6 or 7 years ago now looking at dermatomes, which is kind of like, what's the best way? It's like a map of like your extremities about what nerves get sensation in what area. And particularly in the neck, when the nerves come out of your neck, they go into this something called a plexus. This is just like a mishmash of wires that just cross, interact, and they go down to particular parts of your arm. And they actually did a study looking at the traditional dermatomes that were taught and like how accurate they actually are in patients. I think it's like right 50% of the time. In the lumbar spine, it's a little bit easier because the lumbar plexus or the nerve or the wire mesh in the lower back is much less intricate than it is in the brachial plexus. Brachial means arm. So lumbar is actually way more predictable. They actually, would you find that? You find they find a pretty particular pattern, but
Yeah, very occasionally. Yeah, you hear it and you're like, well, it definitely sounds like L5.
Yeah.
100%.
Yeah.
And you know, you look at the MRI, and you're like, man, it's S1. What's going on? Yeah. Yeah, it's funny. I think that study. So my fellowship director did a study just similar to that, where he had patients, kind of bodies and everything drawn on there with where they felt their pain.
Yeah.
And then they overlaid all of those. And coordinated those, you know, directly with MRI imaging, and they found that they all were all over the board.
Yeah.
And it doesn't surprise us sometimes.
Yeah.
And sometimes we see it and it 100% correlates, and
those are nice.
We walk out like, the world makes sense.
Yeah, the world makes sense. Those are the best times.
You know, it doesn't happen often, but when it does, it feels good.
Yeah. I've had patients look at me weird. I'm just like, oh, your textbook. Like, your face lights up. You're excited because like, this is something I learned, instead of be like, maybe. Yeah. And you know, then when we do our thing, trying to figure out exactly if that is the problem, because unfortunately, you know, with spine, going back to another study, this was done probably 20, 25 years ago. They took 100 people, no back pain, no nerve pain, nothing, over the age of 40 or around the age of 40. And they MRI'd 100 of those people. Guess how many people had disc herniations, stenosis, degeneration? Guess what percent?
Probably more than 50.
Close. 45%. So just because it's there doesn't mean it causes pain.
Yeah.
Now, sometimes people's spines look absolutely perfect and they hurt. And the spine is a very complex thing. Everything attaches to your spine. All the muscles, the majority of the muscles attached to it. It's like you were saying, these areas you can get pain, and sometimes we don't have a good answer. And it's hard to hear that. But you know, we're trying to figure out, because it literally is. Sometimes it's trial and error. You know,
it can be difficult. Health conditions, things that have just layered themselves on over the years, and trying to tease through some of that stuff. But yeah, anyway, that's why we work as a team. Just plug. Yeah. Catch that? But no, I mean, that's why we work as a team. Yeah. You know, to kind of bounce ideas off each other, and we've got the full spectrum of, you know, shoulder, hip specialists, spine specialists to tease things out and get the right answers for you.
I can't tell you how many times during clinic I'll go walk to one of my spine, go to you, or I'll go to one of my shoulder specialists. Somebody be like, "Hey, will you look at this? Can you give me your thoughts on this?" Another one of my other partners, spine surgeon, we'll have clinics together and be like, "Hey, take a look at this. What do you think?" So it's always we don't work in a vacuum, because reality is a lot of things work together. So we definitely work as a team. Yeah. But I was actually thinking about one thing, going about that study your attending fellowship did.
The one you were talking about with the just
drawing the pain,
all of their pain, just diagrams all overlaid on top of each other. And
Did you ever read the original study? I think it was like Finkelstein, or it was a doctor beginning F. It was done in the 70s. This is kind of like where medicine was and is now, but they basically take a bunch of people wide awake and shove a bunch of fluid around the nerve roots and see exactly where that caused pain in the patients, and that's how they determine these dermatomes.
Mm-hmm.
Yeah.
Yeah.
So we've come a long way.
Come a long way. We know where things are now.
Yeah, we know where things are now. Yeah,
But,
standing on the shoulders of giants, as they say. Yeah.
It's good. That's how you figure things out, and that's why we have advancements we do now, I guess, in a way. But yeah. Questions from the audience?
Yeah. Any questions, anybody? No.
Okay. You running out of stuff to say?
No, we got a lot of stuff to say. It's just, we're sitting in front of a live studio audience, probably, what do you say, 100, 150 people? Yeah. I mean, they're all very quiet, very tentative.
You're going to add in clapping and like some people like coughing in the audience.
We got a soundboard. I got some other stuff we can talk about.
Yeah.
So we kind of concentrate on the neck area. Let's go to lower back, because everybody's got lower back pain. I don't think anyone's not had back pain.
Yeah. I would say probably number 2 complaint, maybe number 1 complaint.
What's your number 1 complaint that you see?
Back pain.
Back pain, yeah. Same here. Yeah. Back pain. So, going from the neck to the lower back, you would think it's the same physiology, the same, pathophysiology, and you just do the same things. But unfortunately, of course, just like everything in life, it's not that simple. Mm-hmm. And this is where it get difficult too, because, as a surgeon, we used to think we could cure back pain by fusing things, and it worked good for a year or two, and then they'd have more pain from adjacent level disease for all those taking notes. And then they get relief for a couple of years and they have more pain. And then, that's where you hear the stories about, I had one back surgery, or my grandma had one back surgery, and usually had another back surgery, and she was never the same. She never got better. And we used to fuse dark discs. So when you look at an MRI, it's basically looking at fluid. Your body's full of fluid. You're basically just a giant bag of water. It's basically really, really what you are. And when you get certain degenerative or inflammatory changes, it can change the color of certain things. So when discs turn black, it means they don't have a lot of water in them. And discs basically work because they're hydrated. They give cushion. So when they start dehydrating, a sign of degeneration, that can cause back pain. Just like it's a joint, just like anywhere at your hip, your knee, your shoulder. It's just the way we just don't have. So talking about disc replacements to the neck, they tried disc replacements lower back. That just didn't work, because unfortunately, when the disc starts to wear out in the lower back, it puts a lot more stress on the posterior joints, because you've got joints in the back of your spine, and those can wear out faster. And that's where a lot of the issues in the back come from. Mm-hmm. But there's also stuff in the disc. And so we just don't do a lot of fusions of just bad discs. Now, if there's been a change in position, some type of trauma, some malalignment or something, that's something that we can make better. But we just have this dark disc causing pain. It's hard it's not really indicated to treat surgically. But I know we were talking before this, there's a newer kind of, I don't know, how new is it?
BVN ablations?
Yeah.
Like 10 plus years.
10 plus years, okay.
But yeah.
But they're starting to pick up steam. People are starting to look at them more. But what does BVN stand for?
So one of the things, so when we start seeing these like dark discs, there's a very intimate connection between like your disc and your end plate.
Yeah.
And
end plate's the piece of bone right next to the disc.
Yeah. So you've got like 2 edges of bone here, like solid bone in the middle, and then below that's the disc, right? And so very intimate connection there. There's actually a lot of vasculature in that area of the end plate, and nutrients will pass kind of through there, in between there and the disc. And as we get older, our discs break down, and they start to, like the end plates start to become a little, sclerotic, and have little, we believe to be microfractures that happen. Yeah. And you've got nerves inside your vertebral body. The basal vertebral nerve is what the BVN stands for. Mm-hmm. And so it sits down, kind of like midpoint of the bone itself towards the back third. And its job is to basically take information from the end plates, which again have that kind of intimate connection with the disc, and take that pain in and relay it to your brain to say, hey, like my back hurts.
Yeah.
And so, depending on the age of the person and how long this has been going on, you may see those things on MRI. So we always look for those modic in play changes. If we see those things, we can say, okay, well, maybe, this is a piece of their pain. And if they're older, usually I'll kind of rule some of their facet joints out and say, hey, maybe let's block some of these joints in the area, see if your pain gets better. And if it does, well, it's probably your facet joints.
Yeah.
And if it doesn't, sorry. Yeah, well, I should have said what the facet joints are.
And so as we were talking about, the disc space where the disc is a joint. The joints in the back in the posterior back part of your spine, they're called the facet joints. And they're what allows motion, basically. Yep. And so just like hip, knee, or shoulder, they can degenerate just like anything else. And so, we can go in and block those. Yeah. Just like you do a hip or knee or shoulder injection to see if it can help the pain. Yeah.
Yeah. And so, kind of, I guess moving back, we'll get back into this. But,
sorry.
No. I was, moving back and taking a step back, even from that being, like some of the more basic way I break down back pain for people is like pain that just stays in your back or pain that's like in your back shooting down your leg. Right. And, anything involving the leg, we worry about nerves and we're thinking about that. But for stuff just in your back, we think about the disc and the end plates, and those are on the front. And on the back side of that bone is where the facet joints are. And so naturally in life, the disc degenerates, and then maybe that progresses into involving some joint pain. But the younger people, usually it's disc. Yeah. And so has over the years been all these interesting ways to try to treat the disc and disc pain and disc tears. And can we inject things to seal up a tear? Yeah. Can we use heat to try to, essentially almost cauterize, the inside of that annulus and get it to seal back up?
I've never heard of this.
Yeah. Oh. Yeah, they had an IDET procedure that people would use to try to do that. But basovertebral nerve ablation came about, and people started looking at this nerve and saying, okay, maybe these end plates are actually where the pain's coming from. And so there's younger people, you want to make sure, is it the end plate, is it the disc? And so the old way used to be discography, where you would take a needle and pressurize the disc. And if it hurt, that meant that, you had a tear in the disc that was painful, and we could treat that. No,
it just causes the disc to degenerate faster.
It's some of the ways that we treat the sometimes but it also involved poking holes into discs that maybe weren't painful yet for somebody and who caused issues down the road. So it's fallen out of favor. We don't do that anymore very often. But for those tears, sometimes I've been injecting platelet-rich plasma into the disc and trying to see if that can kind of bolster, augment the healing response from the disc itself.
Have you found good results with that?
We've had good results. I think you've got to be really careful about who you choose. That's what I found.
Who do you find benefits from it?
I would say, younger people who don't have maybe some of those sclerotic changes on the end plate yet that you might see.
Minimal degeneration.
Yeah.
The dark disc, but
single level disc.
Yeah.
It's got a break tear on it on MRI. You've ruled the facet joints out, and they've got classically flexion-based pain. Not always the case, but again, we were talking earlier about textbook stuff.
Yeah.
Ideally, you see some of that, like bending forward, twisting. You're loading the disc a lot. So anyway, sometimes we'll dabble in that if we think it's disc pain. Yeah. And I found that to be the most helpful of treatment options out there for the disc itself. Then, there's the other possibility. Is this that nerve inside the bone? Is it the actual end plate, inflammatory changes that are causing pain, or degenerative changes? And so, once we've ruled everything out, you kind of look at the person and see if they have tears, and if you think it's a disc, or do you think it's the end plate? So if we think it's the end plate, we might move down the route to think about the basovertebral nerve ablation procedure. And And so for that, you get into the vertebral body, and you use radio frequency to create heat to kill that nerve off. So now you don't feel the inflammatory changes from the disc end plate.
Is there like a way to determine, because this is relatively new to me. So is there a way to determine before you do the ablation if that's the problem besides just imaging?
No.
Okay. So again, it's sometimes it's trial and error stuff.
No, there's not a great way to prove it's the base vertebral nerve or the actual end plate. Besides ruling everything out and knowing this is more than likely, not disc. I don't see any fresh tears on there. Yeah. I probably already ruled the joints out. What else is causing just icky back pain? It doesn't feel like muscle. Again, kind of feels like it's in that anterior column portion of the spine. Yeah. It's probably the end plates. You can go into it with better confidence that way. But there's still that piece, Yeah.
I mean, again, trial and error. I mean, sometimes it's just like, this is our best guess. We can try it. But, the nice thing about some of the non-operative stuff, you're not really burning a lot of bridges. Right. There's not, the risk with those procedures is pretty low. Or surgery, you're doing surgical risk. And then if I have to do a fusion, you're losing motion at a level, and that motion does not come back. Yeah. So, you're basically, you're burning that bridge. There's no going back from it, which is why we don't just jump into it. Like if I talk to you about a fusion, it's like, that's all we got. And fusions done for the right reasons have good success. Yeah. Just done to see if something's going to stick to the wall is not a really good indication to do it. Yeah. I think if you look at the spine world in general, I think most of us are a little more hesitant to jump into surgery. And so, it's got to be the right person, the right potential outcome with risk factors. And, we've kind of tried everything we can. Yeah. So, and I think too, you can speak to this just as well as I can. The patients that typically really do respond well to treatment are the ones that their main issue is nerve pain from the from the degeneration, narrowing the spinal canal, pinching the nerves, causing issues with, pain with walking, hard to sleep, pain down the leg, limiting activity. Those are the patients that typically do the best because we know we can make nerve pain better. Yes. Yeah. Horribly miserable when they come in. Yes. Sometimes wheelchairs, barely walking, crawling the table. Been to the emergency room already, 2-3 times. Yep. Those are the dramatic changes that you can see sometimes in some of those, which are obviously also super rewarding, right? So you do a shot, doesn't work out, or you're worried about how bad it looks, and we're not going to mess around with injections. You need surgery. So having those conversations and just getting you to relief is what we want. So, I've seen several people you've treated. You've seen several people I've treated. Tell me about a story from someone who you treated and just like, this is what I love. This is why I went to become a spine surgeon. Yeah. Well, recently, we didn't talk in depth about this, but sacroiliac or SI joint fusions. I had a guy that he had a hip replacement, he had a back surgery, he had all sorts of injections and never got any relief. And he came to see me, and I was looking at all this stuff, being like, well, while it's kind of, your SI joint should not move. When you've had all these things done, sometimes it can cause some micro motion. When I say micro, like nanometers, like your body picks up on that stuff. And so we did the injection. He got 100, got significant relief. And we did the fusion, and all his pain that he had numerous surgeries for years went away. So, that's a good one, but probably my favorite ones are my cervical, my neck patients, not necessarily the disc replacement ones. Cause this is going to sound so stupid, but 99% of them are happy. Bad arm pain. Had a young mother who couldn't pick up her child or her baby because of a disc herniation. Disc replaced her. She's picking up and playing with her kid now. But one of my favorites recently was a local guy, super nice guy, but he had such bad degeneration. The neck was actually pushing on the spinal cord, like he was becoming like almost wheelchair bound. And it's called myelopathy. It's basically like a slowly evolving spinal cord injury, but he also is a local winemaker. So he uses his hands. He's out, walking the vineyards. And I had to do two-level fusion on him, and hand functions come back. He's now, walking independently. He uses a cane at this point, but, he can't going from almost wheelchair bound to walking independently. It takes a while, but, he's back to enjoying his life. And basically he was he was having his spinal cord slowly damaged, and we're able to reverse that. So those are some of my favorite ones.
Absolutely. Yeah. But I love that story. That's, I think what we all strive for, right? Have those patients that come in, give you that hug and tell you you've changed your life forever.
Enjoy a good hug.
Yeah. I mean, that's what we all want, right? In the end is just, someone who's happy and you've changed their life. That's what I love to hear in the office. That's what I know all of our partners love to hear.
Oh, yeah.
So, anyway, thank you everyone for joining us today on this podcast. And
hopefully you've learned something, got some information. We are, he's mainly at Oak Ridge. I'm mainly at Park West, but we have partners also downtown, Alcoa, Fountain City area, also Bearden. So a lot of convenient locations around the East Tennessee area. So whether it's myself or Dr. McGuirk, we've got excessively talented, intelligent, hardworking people who want to help you from a spine standpoint or any orthopedic standpoint. So please, if you've got any issues, make an appointment and we'll see what we can do.
Absolutely.
Yeah.
Thank you guys.
All right. Have a good day.